Welcome to Medical Lab Science Quick Review. Our topics are a continuation of the physical characteristics of urinalysis, which are urine clarity and specific gravity. Afterwards, we'll go over questions and answers based upon our MLS ACP Board of Certification study guide. Urine clarity describes the transparency, haziness, cloudiness, or turbidity of urine specimens in routine urinalysis. Ideally, we obtain a clean catch early morning specimen that we can process within 2 hours to avoid bacterial overgrowth. Automated UA instruments usually require at least 2 milliliters of urine volume. In the outpatient setting, the patient usually collects. In the hospital, the nurse usually collects. If it's not possible to test within 2 hours, then it's best that we refrigerate the specimen. What happens if we do not preserve urine samples or refrigerate them within 2 hours? We see bacterial growth, and that leads to cloudiness. Bacteria will consume available urine glucose. Some will produce ammonia with urease enzymes, making the pH more alkaline, causing more cloudiness from amorphous phosphate crystal formation. In time, white blood cells and red blood cells deteriorate, and casts begin to disintegrate, making identification more difficult. And we'll see other changes listed. After mixing the specimen well, looking through a clear container, and using a good light source, we use common lab descriptions to describe urine clarity. We can see many causes of non pathological turbidity. Amorphous urates and amorphous phosphates are common causes of urine cloudiness and turbidity. Amorphous urates are crystal urea without a specific defining shape, seen in the light microscopes using the high dry objective at 400 magnification. They form when certain minerals in a urine clump together with other substances to form small, solid aggregates that are seen macroscopically as cloudiness, microscopically as small amorphous crystals, sometimes in aggregates, usually found in acidic pH less than 5.5. They are generally considered clinically insignificant. Many factors are involved in their formation: dehydration, salty diet, protein diet, fruits and vegetables. Also, medications. Likewise, amorphous phosphates are similar to amorphous urates, except that they are seen in pH greater than 6.5. Clinically, they are also insignificant by themselves, but they might be associated with calcium metabolism, bone and parathyroid disease, and kidney stones if there are other signs and symptoms. Here we see a list of pathological turbidity in urine. We've seen red blood cells and how they affect the turbidity from our previous video. A cloudy urine, ammonia like odor, positive leukocyte esterase in the urine reagent strip with leukocytes and bacteria in the micro strongly hints at signs of a urinary tract infection. In urinalysis, it is the density of a urine solution compared to the density of distilled water, which has a specific gravity of 1.000. Urine specific gravity is a valuable parameter to measure the kidney's ability to concentrate the glomerular filtrate. The specific gravity of urine filtrate is normally about 1.010, which is called isothenuric. Below 1.010, it is termed hyposthenuric. If it is 1.001, it is probably not accurate. It's probably diluted with water. Urine specific gravity above 1.010 is termed hypersthenuric. Our ACP study guide lists normal random urine reference range as 1.003 to 1.035. Urine-specific gravity is commonly tested in the clinical lab using automated instrumentation that measures light of a specific wavelength that reflects off the urine region pad that was soaked with the urine sample. This instrument methodology is known as reflectance spectrophotometry. The backup method is manually read using manual reagent strip methods. As we compare the reagent color pad colors, we see that the closest reading is urine specific gravity of 1.015. It is a semi quantitative measurement because it is actually a range between 1.010 and 1.020. Polyelectrolyte ions is the urine reagent strip methodology, and it is based upon the pKa or dissociation constant of a polyelectrolyte in an alkaline medium. Bromthiamyl blue indicator shows low specific gravity with low ion concentration in the alkaline blue region, and yellowish green with high ion concentration in the acidic yellowish green region. Low urine specific gravity is associated with a dilute urine sample, while a high urine specific gravity is associated with a concentrated urine. Urine specific gravity can also be measured by an old tool called the refractometer. It is antiquated by today's standards of urine chem strip analysis, but the ACP study guide asks several questions about urine refractometry, refractive index, and correcting for glucose and protein. What is refraction? It is the bending of light, and we're familiar with it around our world every day. The refractive index of an optical medium is the ratio of the speed of light in air or vacuum to the speed of light in the medium. FYI, for those interested in physics, there's an equation. Using a clean pipette, place a drop of urine sample onto the cleaned glass prism. Gently close the plastic cover over the glass prism and look through the scope at a good light source. Let's use the scale on the left. This is read as 1.040. This is read as 1.018. There are calibrations and controls using sodium chloride and sucrose. Distilled water should be measured at precisely at 1.000. Our ACP study guide asks a question about which substance must be corrected in urine refractometry. It did not actually ask for a calculation, but which of the following must be corrected while using a urine refractometer? The answer should be either protein or glucose because of their disproportionately large size mass. The refractometer has its limitations, one of which is X ray contrast dye. X-ray contrast dye will exceed the upper limits of the urine refractometer. In this case, the best method to measure urine concentration when there is an X-ray dye interference is to use osmometry, which we will cover in a later video. As you may have seen in my previous video, you can see the osmotic gradient go from 300 milliosmoles per kilogram to 1200 at the loop of Henle. This system is known as the countercurrent multiplier system. So we see how urine specific gravity is a quick and easy parameter to measure in a UA to assess for kidney concentrating ability. But we also understand that urine osmometry is more precise and accurate to measure kidney concentrating ability in milliosmoles per kilogram, which is often compared with the patient's serum osmolality. The following questions and answers are similar to the ones in our ACP Board of Certification Study Guide. Thank you for your time, attention, and support, and we hope to see you in the next video.